Welcome to another episode of Fork Candles, where we explore medicine, child neurology, and critical appraisal skills. As always, this is an educational endeavor and should not be interpreted as medical advice. Each patient and situation is unique and should be addressed by your personal healthcare provider. The trial I have for you today is the Childhood and Adolescent Migraine Prevention trial, also known as the CHAMP trial. This was published in the New England Journal of Medicine in 2017 that compared Amitriptyline to Topiramate to placebo. Now, this is a great trial that's pretty self-explanatory when you read the trial, and the discussion section is a fair and honest assessment of the trial. But every time I hear people talk about this trial, I hear misinterpretations of what the trial actually found. So I have to keep going back and rereading it thinking that I missed something. So today I thought I'd bring you my thoughts on this trial. Now, let's first go ahead and look at the comparison arm. And they did receive placebo, which I'm going to come back to in a second, but they also, per their treating doctor, if they felt appropriate for their headaches, they could receive an NSAID or a triptan. In addition to the NSAIDs and triptans, they were also advised to have behavioral therapy for headache management. And basically, this is just advisement on making sure they had adequate hydration without caffeine, regular exercise, counseled them on a healthy diet, and also counseled them on not skipping meals. Everyone in the trial received this, but it's important to know what the baseline received. Now, going back to the issues surrounding the placebo group, the investigators ran into resistance during their grant review because some said it was unethical to have a placebo group when it was clear that amitriptyline and topiramate worked. Now, this is where I really admire the investigators in this trial. They too felt that topiramate and amitriptyline were effective based on their combined clinical experience of seeing and treating thousands of patients. However, they admitted there was still equipoise at the time the trial was started, and I agree with them. There were no large trials testing prophylactic migraine medications in the pediatric population, and the small trials that existed were unimpressive. Now on to the outcome measure. The primary outcome measure in this trial was where they looked at the number of headaches they had at baseline in the first 28 days of the trial and compared it to the number of headaches they had in the last 28 days of the 24-week trial. A patient was recorded as a success if they had a greater than 50% relative reduction in number of headache days over that last 28-day period. There are other outcome measures in this trial worth talking about, but I will spend most of my time here for several reasons. One, because it is the primary outcome measure which the trial was designed and powered to find. Two, this is a terrible outcome measure, but I actually do not fault the investigators because 3, this kind of change from baseline with a dichotomous cutoff is pretty much standard for headache and seizure trials and is actually what the FDA uses for drug approval, despite the fact that statisticians have been arguing against this kind of outcome for decades. Let's look at this hypothetical graph of 3 patients' migraine frequency. On the y-axis is the headache frequency per 28 days, and on the x-axis is time. If we asked this person how many headaches she had in the last 28 days, she would say 10. If we asked at this point, she would say she had 2 headaches in the last 28 days. We can immediately see why it's problematic when the inclusion criteria is also the primary outcome measure. Both a patient's natural regression to the mean and their variability will play havoc with the endpoint. To be included in the CHAMP trial, participants had to have at least 4 headache days from their prospective headache diary over the last 28-day baseline period. Many disease processes fluctuate over time. Take a look at this patient. His headache frequency is ramping up, but he missed the cutoff to be included in the trial. Meanwhile, this patient's headaches are at her peak frequency, and she was included in the trial. The trial will capture an improvement in the natural downswing while failing to pick up those that are ramping up. This could cause trials to overrepresent people at the height of their disease process. See how this patient's headaches have been getting worse for longer than this patient? She probably had more contact with her doctors. More contact with the health system means more opportunities to be enrolled in the trial. A bias towards including patients at the height of their frequency can result in a large placebo response due to natural regression and variability. Another problem is measurement error. There is measurement error with any tool, including headache diaries. None of us is perfect at documenting what ails us. A patient who under or overestimates by a few headaches in the baseline period can be the difference between being included or excluded in the trial. Measuring multiple 28-day periods would correct for random measurement error of under and overestimates. However, in this setting, the inclusion criteria lops off the underestimates and favors overestimate errors, which will then have a natural regression to fewer headaches by pure random measurement error. We know measurement error occurs, but it is not the same as natural progression of the disease. But it is very difficult to tease out and something that impacts the placebo response. And let me just get to the point about something I've been dancing around. There is a difference between placebo response and placebo effect. The response is anything that happens in the placebo group that includes a placebo effect. The effect is a distinct physiological response to the therapeutic context and treatment delivery. Due to pain having large personal perceptual components, it is difficult to separate how much of the response is due to an actual placebo effect. But take epilepsy research, for example, where they also unfortunately use change from baseline metrics based on seizure frequency. I am highly doubtful that a sugar pill decreases seizure frequency, but there is often a 20% or higher placebo response. Now, some people do debate whether there is a placebo effect in there or not, but that is for a different video. Seizure frequency, like headache frequency, fluctuates, and there is measurement error in seizure tracking. Therefore, the overwhelming majority of the placebo response in seizure trials is most likely due to the trial design and not due to some physiological effect. Do I believe that there is a placebo effect inside of headache trials? I do, but I have no idea how much the magnitude is of that actual response. The problems with this primary outcome don't end there. Using a percent change from baseline is statistically inefficient and mathematically awkward. Just to give you a flavor for this awkwardness, if you have one kid that goes from 8 headaches a month to 4 headaches a month, that is a 50% reduction. But if another kid goes from 4 to 8, that is a 100% increase. That is a problem when you are trying to compare groups and the directionality of the change makes that much of a difference. Also, there are ceiling and floor effects. A patient cannot have more than 28 days or less than 0 days of headaches. Therefore, if they come in with 28 days of headaches, they can only improve. And if they have 20 headaches, they can only worsen by 40%, but they have much more room to improve. Lastly, if a kid has a 40% reduction in headache days, she is counted as a non-responder. But if another kid has a 51% reduction, she would be counted as a responder. Are these children really that different? This is what happens when you take a discrete variable and turn it into a dichotomous outcome. By dichotomizing a discrete variable, you are losing information, which means you are losing power, and you require a larger sample size for your study. If you insist on using headache frequency, there might be some solutions, but to me they seem pretty inadequate. Say you have 30 kids that are presenting to your clinic that are interested in enrolling in a headache medication trial. You ask them to keep a headache diary over the next month. They come back and 20 of the 30 have more than 4 headaches per month. We exclude 10 of them. We then randomize them to 2 groups, but we do not start treatment. They present back in another month with a second headache baseline. Now this is the baseline we're going to use, but some of them have below 4 headaches a month because of their natural fluctuations or regression to the mean. Regardless of this new baseline, you will start treatment. Now some might say that this is wrong to start treatment on individuals that have less than 4 headaches a month, but they are just confused. Imagine if we go back to the original 20 with the first baseline, and I randomized them then, and started treating them at that point. Those individuals were going to have improvement whether you treated them or not. So essentially, patients that no longer met the initial baseline criteria were going to receive medication. But with the second baseline, we have a clearer picture of natural fluctuations. This doesn't get rid of all the problems, and personally, I think we should ditch it altogether. Take, for example, blood pressure trials. You have all the issues with natural fluctuations biasing those that get included. But when the outcome is heart attack, death, or stroke, we don't have to worry about chasing those fluctuations as much. The goal of medicine is living longer and living better. Therefore, it would make much more sense if the outcome revolved around improved quality of life. And the CHAMP trial did use the Pediatric Migraine Disability Assessment Scale, also known as the PED-MIDAS scale, which measures migraine's effects on school, home, play, and social activities. This was a secondary endpoint in the trial, and the investigators claim it is reliable, valid, and importantly sensitive to understanding the impacts of migraines on pediatric quality of life. If it really is that good, it should be the primary outcome in future headache trials. Now, I'm not sold on this being the best outcome measure because I haven't looked too deeply into the PED-MIDAS scale. But if our goal is living better and living longer, then counting up headaches doesn't seem like the right outcome measure. I'll leave the outcome measure there for now. Let's go ahead and look at the population.
I think the investigators did a great job at obtaining a sample of patients that allows generalizability of the study's results. There is an entirely separate publication that goes into considerable depth of the patient's headache characteristics, frequency, and demographics. I will leave a link to that publication below.
Another great advantage is that the entire population was blinded to the treatment they received. However, I did not see whether or not the investigators examined if the patients were able to tell if they were on treatment or not. If they were able to detect that they were on treatment, this may influence whether or not they think it's effective.
The main issue I have with the population is the unequal randomization. For every 2 people that got randomized to each treatment group, only 1 was randomized to placebo. For the life of me, I could not find the reasoning for the unequal randomization. I looked in the 2013 protocol publication, the baseline characteristics publication, and the final results publication. Please let me know if you find the justification published anywhere else. I'm not a big fan of unequal randomization. You can make valid arguments for it, but you need to state the specific reason. I personally cannot think of a valid argument for unequal randomization in the CHAMP trial. Unequal randomization is a much bigger discussion than I'm willing to have here, and I do not think it is critical to interpreting the results from the CHAMP trial. So I will leave links to articles that discuss unequal randomization in the comments section for your interest. But let's go ahead and get to the part that sticks in most people's mind about the population. The study was stopped when there was only 144 in the amitriptyline arm, 145 in the topiramate group, and 72 in the placebo group. I constantly hear people say that the study was stopped early due to poor recruitment, and if it had run longer, it was likely to find an effect. This is simply not true. The trial was stopped based on a pre-planned analysis for futility. You can read about the stopping protocol in the 2013 publication. Of course, this doesn't mean there isn't a difference between the medications, but the way the trial was designed, with the outcomes they chose, the chances of observing a meaningful effect was deemed too low to continue the trial. The published pre-planned analysis is just another reason to like this trial. Sometimes it is difficult to find the stopping rules used in other trials that are stopped early, and then speculation fills the gaps of what should have been or could have been if they had just gone on. Now for a quick check at the dosing in the intervention groups to make sure it's appropriate. The target dose for amitriptyline was 1 mg per kilogram per day with a max daily dose of 100 mg per day. For topiramate, it was 2 mg per kilogram per day divided into 2 daily doses with a maximum total daily dose of 200 mg. Here is a schematic of their 8-week titration plan that allowed for adjustments every 2 weeks based on the effectiveness and tolerability. They could maintain the current dose, reduce the dose, or continue the up titration. However, if there were 2 reductions due to side effects, then the patient would have to come off the medication. There is much more detail in the 2013 publication that I will not go into here. The dosing and escalation appears appropriate to what is seen in normal practice. Therefore, claims against too high or too low dosing are unfounded. After the titration phase, there was a 16-week maintenance phase of the highest dose achieved. Before we go on to the data, it's always important to understand what the investigators expected. They powered their study based on 4 prior studies. 3 suggested that between 54% to 95% of the patients taking topiramate would have a 50% reduction in their headache days. And 1 study suggested that 70% would reach that mark if they took amitriptyline. They noted that the placebo response rate in those 4 trials ranged from 45 to 52%. Therefore, they powered their 3 hypothesis study to show that 70% in the treatment groups achieved a 50% reduction in headache days compared to 50% in the placebo group. And they powered it for the possibility that 85% of the patients in the topiramate group achieved that primary endpoint compared to 70% in the amitriptyline group. Because they had multiple hypotheses, they used a Bonferroni correction. The investigators felt that this 20% difference between placebo and treatment was clinically meaningful. Now, I'm glad that they based their power calculation on something they felt was clinically meaningful rather than something they could find, and I personally think that there probably is a difference. However, I think it's rare to find a medicine with an absolute difference of 20% when the placebo response is already close to 50%. Additionally, using a Bonferroni correction is a rather stringent correction. Putting this together with the problems of the actual outcome measure discussed before, I wouldn't have expected this trial to be a positive trial. Now onto the data, which I've pretty much already let you know what the trial's results were. It was a negative trial all around. They failed to detect a difference between placebo, and there were more harms in the medication groups. Does this completely close the door on these two medications? No, not necessarily. Beyond the use and handling of the outcome measure, I think other designs could show some small effectiveness for topiramate and amitriptyline. Do I think we should move on from these drugs? Yes. If there is a benefit, it will most likely be small and probably outweighed by the harms. Since the publication of the JAMA trial, a 3-year follow-up was published of patients that participated in the trial. You can see from this graph here that regardless of the treatment group, including placebo, they consistently maintain their reduction in headache frequency. And this is in lieu of the fact that less than 10% of the patients continued on preventative medication. Interesting, you see a large drop in the Pediatric score of the placebo group 3 months after the trial was over. Do you think this is a result of finding out they were on placebo the whole time, or perhaps they had guessed they were on placebo during the trial and they were just glad that the trial was done? I'm only speculating here, but it is an interesting drop. Additionally, a 2020 meta-analysis did show a possible benefit for topiramate and propranolol, but neither had significant predictive confidence intervals. And I read all the trials that made up the meta-analysis, and it's more of the same. Garbage in, garbage out. Therefore, I think it would be wasteful to do another trial testing topiramate or amitriptyline for headache management. Of course, I am always willing to change my mind if another well-run trial with a meaningful outcome measure is used and does show benefit. Now some housekeeping. Some people sing the praises of the placebo effect and the baseline behavior modifications in the JAMA trial as the silver lining to the findings. This is a gross misinterpretation of the data. Maybe there is a larger placebo effect inside of the placebo response. Maybe there wasn't. Maybe the behavioral modifications made a difference. Maybe they didn't. The JAMA trial in no way provides evidence for these claims. There are other trials that are suggestive that behavioral modifications may make a difference, but you cannot read the JAMA trial and distinguish how much of the placebo response is placebo effect, or what benefit is coming from the behavioral modification and what isn't. The real praise should go to the investigators that are committed to the problem and not the solution. I encourage you to read the background story, the subsequent articles about the trials, and the follow-up research. There are parts that I could nitpick and disagree with some wording about how the authors interpreted the trial, but overall, you can tell they are true clinician scientists trying to improve the lives of their patients and advance our knowledge about the world. They don't care if it's topiramate or amitriptyline. They ran a trial and they accepted the results. And this brings me to my last point. I need to address those that still do not accept that the best evidence we have shows that there are more harms than benefit when giving topiramate or amitriptyline. I will often hear them argue to me that their clinical experience of their patients getting better on topiramate and amitriptyline have them question the results the most. So I want to entertain a thought experiment. Let's say you travel back to 1750, where physicians are reporting that they are experiencing their patients having a net benefit from things that we now know are only a net harm. And you see a patient that is dying of bacterial pneumonia. Of course, everyone else is attributing this to an imbalance of the patient's humors. You unfortunately did not bring any antibiotics from the future, and you have no clue how to create them. The family and patient beg you to do something. You sit and comfort the patient, but explain that you do not have any interventions that will help the patient. Your colleagues and the patient's family accuse you of not being empathetic to the patient's suffering. The patient then goes to another physician and is properly bled. Now, I am in no way saying that amitriptyline or topiramate are equivalent to bleeding. As stated before, I wouldn't be surprised if there is some mild benefit to these medications, but we have not detected it because of how the trials are designed. I use the historical thought experiment to show how caring physicians can be undermined by other clinicians. If you resist prescribing some of these medications, you will inevitably hear your colleagues and patients say, "Have you ever had a migraine? If you had, then you would be more sympathetic." Or, "Do you not believe your patients?" Substitute that logic back to 1750. Would you bleed that person to be empathetic? Would you not believe that they are truly ill? Of course I want to give something that helps a patient's migraines. Of course I believe they are suffering. When other clinicians are willing to treat the migraine, then I cannot blame the patient for feeling animosity towards me. The treatment seems like a validation. Yet the burden of proof is on the person making the claim of benefit. So far, the best evidence has not detected any benefits for pediatric migraine prevention, and only harm. So that's it for now. Please let me know what I overlooked or got wrong in the comment section down below. And remember, as always, human diseases and disorders are problems to be solved, not contests to be won. Let's help each other solve them together.